So good afternoon, everyone. Welcome to our cardiology round. It's actually the first in this academic year. So it's my pleasure to introduce our guest speaker, Dr. Subodh Verma. So Dr. Verma is actually well known to all of us. He's internationally well recognized. But because it's the beginning of the year, there are new trainees actually starting. So just a brief introduction. So Dr. Verma is a cardiac surgeon at St. Michael's Hospital. He's a scientist at the Keenan Research Center and a professor of surgery and pharmacology and toxicology of University of Toronto, and also a Canada research chair in cardiovascular surgery. So again, he's very well known actually for his research. He has led many important, international trials, particularly in diabetes, and a leader actually in GLP-1 agonist research. And so he's also the editor-in-chief in Current Opinion of Cardiology, associate editor of the Journal of Thoracic and Cardiovascular Surgery. And he has also played an important editorial role in the European Journal of Heart Failure and editorial consultant for JACC as well. He is extremely well published with a H index of 135 as of May 2025. And today he's actually going to talk about one of the novel trials, actually the STRIDE trial, for which he has also played a leadership role. Thank you, Dr. Verma.
Well, thank you, Andrew, and welcome to everybody to the new year, and to all of the new trainees who are joining. Welcome to St. Michael's Hospital, and really delighted to always share some of the insights. And I know that people are in and out on holidays, so I'll make sure that this is also sort of a short and sweet. So the STRIDE trial was presented at the American College of Cardiology meeting earlier this year. There was an update that was presented at the American Diabetes Association meeting a few weeks ago, and there will be more updates that will be presented from this trial at the European Society of Cardiology. The trial has, although has just been presented from the American College of Cardiology, has actually led to a new sort of recommendation from the European Medicines Association for the use of semaglutide in the treatment of people with peripheral arterial disease and diabetes. So not only has this been an important trial, but it has rapidly transitioned into what we think will have immediate clinical impact for people living with PAD. This was a trial that Mark Bonacca and I were involved in a leadership capacity, and the results were presented in the Lancet earlier this year. So the most comprehensive review on the burden and epidemiology of peripheral arterial disease in people living with diabetes was published last year. And you can see from our institution, Dr. Lawrence Leader and I really co-led this analysis published in Diabetes Therapeutics. And it really underscores the unmet need of PAD and PAD treatments in people, particularly with type 2 diabetes. Now, some of you may already know that PAD is a global and recalcitrant problem. It affects over 250 million individuals, actually. It is often underdiagnosed. It is the common first cardiovascular manifestation of type 2 diabetes. And when we, tell people from a cardiovascular standpoint that myocardial infarction and stroke and heart failure are the first are not the first manifestations, they often actually wonder, how is that the case? But epidemiology confirms that PAD develops early, is common, and in many cases could be the initial manifestation of a cardiovascular event in people living with diabetes, accounting for about 16.2% of all first cardiovascular events. What is particularly important in people living with diabetes, similar to the coronary circulation, is that there is diffuse and distal disease. And PAD in type 2 diabetes affects the small vessels below the knee, often making it less attractive or less amenable to revascularization. And this has been the Achilles heel of PAD and diabetes, is people actually develop symptoms of claudication. The claudication is associated with, multifocal atherosclerosis involving, small vessel disease below the knee. They're not amenable to either surgical or percutaneous revascularization, and hence, the disease progresses with worsening symptoms and oftentimes ends with limb loss. In the United States, there is a class 1 treatment for claudicants or claudication, and that is cilostazol. As you know, in Canada, cilostazol is not available and is not approved. But nonetheless, cilostazol was approved for the treatment of claudication a quarter of a century ago, 25 years ago. It is poorly tolerated. It is contraindicated in heart failure. And while it does have modest effects to improve walking distance in people with PAD, it has no additional cardiovascular benefits with respect to reducing major adverse cardiovascular events. So, the natural history of PAD and diabetes is a really important one. And, coming back from the American Diabetes Association meeting a few weeks ago, it is one of the sort of top priorities from the American Diabetes Association, from the Society of Vascular Medicine, to find solutions to improve quality of life, quantity of life, prevent limb loss in people with PAD. Now, we have a lot of interest at St. Michael's Hospital in diabetes and peripheral arterial disease. And as you know, Charles Demestriel from our institution actually is actively involved in studying that. And Charles and myself and David Mazer are working on a chiropody-based intervention in dialysis units to prevent amputation. And that trial is a SPORE trial that was funded a few years ago. So there's lots of interest, again, at our hospital, both in terms of epidemiology, but also in terms of clinical trials in this space. Now, a few years ago, Mohammed Hussein, who was one of Muhammad Al-Amran's PhD students, along with Charles Demestriel, you can see here listed as the senior author, and a few others, actually evaluated and studied the population-based secular trends in lower extremity amputation for diabetes and peripheral arterial disease using the ICES database. And quite surprisingly and unexpectedly, and regrettably, if I may, lower extremity amputations in Ontario related to diabetes or peripheral arterial disease or both increased over the last decade. And it just highlights the fact that, this is not a problem that, we are winning. There's a burgeoning burden of diabetes, and we have great therapies such as SGLT2 inhibitors and GLP-1 receptor agonists now to help treat major adverse cardiovascular events, as well as treat, A1C durably. But none of those therapies have been evaluated specifically with respect to their impact on improving, claudication symptoms or patient-reported symptoms from a PAD standpoint. Now, remember, all these medications are used regardless of whether people have PAD or not. And in fact, many have said should be prioritized in people with PAD primarily to improve or reduce their major adverse cardiovascular events or MACE events, but none of them have been used or prioritized for, primarily limb outcomes per se. So as I just mentioned, cilostazol is available in the United States. It was approved 25 years ago. It has no additional CV benefits. It's poorly tolerated. It's contraindicated in heart failure. And the data that led to the improvement, led to the indication for cilostazol or approval was based on a flat treadmill, sort of 40 meter a mean improvement in walking distance. Now, I want you all to remember that the gold standard for approval of therapies at the FDA and EMEA at this point in time appears to be a constant load treadmill at a constant speed of 2.3 miles per hour or 3.2 kilometers per hour at a 12-degree incline. That is the FDA standard. And, that usually equates to sort of twice the distance that people would walk if they were walking on a flat surface. So just keep that in the back of your mind as we evaluate the results of the STRIDE trial. Now, semaglutide, as you know, or Ozempic, is the sort of the first in a series of, I think, about 10 different strategies that are GLP-1 RA based that have transformed, the landscape of cardiometabolic disease. I think you're all quite familiar with the data set on, its anti-hyperglycemic effects and its effects on weight reduction. But there's a whole host of other benefits of GLP-1 receptor agonists, including, reducing inflammation, reducing blood pressure. I was involved in the STEP HFpEF trials. As you know, I presented that at these rounds actually last year, where there was an improvement in functional outcomes in people living with heart failure and preserved ejection fraction, and that led to a change in the guideline recommendations for the use of semaglutide in HFpEF. Then there was a trial called SELECT, and SELECT was a trial in which we used semaglutide in people who did not have diabetes but had had a prior, atherosclerotic cardiovascular event, and it reduced MACE events by 20%. That also led to a Health Canada and FDA indication for the use of semaglutide in people without diabetes who have a prior history of myocardial infarction, stroke, or PAD to reduce MACE events. There have been data from trials like the FLOW trial that have shown efficacy of semaglutide to improve kidney outcomes. And then, of course, there were some prior analyses from the liraglutide studies from LEADER and others, which hinted towards a reduction in rates of amputation. And therefore, given the really pleiotropic and multitude of benefits that these drugs have on quality of life in heart failure and quantity of life in people with atherosclerosis, reduction in inflammation, and other cardiometabolic risk factors, I think it was a leap of faith when we started this trial to say, could this be a strategy that could actually improve functional outcomes in people with diabetes and PAD? It was a high risk, high reward kind of, thesis, if I may, because there was really not very much other than the prior smallish data with liraglutide suggesting it may reduce rates of amputations, but amputations were not very carefully captured and were not homogeneously defined. And therefore, there was a lot of equipoise as to whether or not this would hold true. So we embarked on this journey to answer the following questions. That is, in people with symptomatic peripheral arterial disease who have diabetes, will semaglutide used at the diabetes dose of 1 milligram given once weekly, would it improve function? Would it improve symptoms? Could it improve hemodynamics, i.e. improve the ankle brachial indices? And finally, could it actually arrest progression, i.e. lower rates of rescue therapy? Rescue therapy defined as drop-in with intensifying pharmacotherapy, revascularization, amputation, or all-cause mortality, a good surrogate for progression of disease. So to that end, we studied people with type 2 diabetes who had peripheral arterial disease and had symptomatic claudication. Now, I will define this in the next few minutes. These were not just people who said, I've got diabetes and I've got leg pain, because that's not sufficient. That's not a sufficiently objective way to make sure that you're capturing people with documented PAD. And therefore, you will see on the right-hand side of this slide under the green box, we enrolled people with early stage Fontan stage 2A PAD. And what is Fontan stage 2A PAD? This is the earliest symptomatic stage of PAD. So one is we wanted to see if early on in the journey of, or the natural history of PAD, this therapy could be beneficial. But we also used the Fontan staging as an inclusion criteria because it actually provides an objective sort of metric of defining, how much people can walk and can't walk based on the following two characteristics. And that is that the pain-free walking distance must be greater than or equal to 200 meters on a flat treadmill. So they've got to be able to walk more than 200 meters on a flat surface. So remember, all of the sites get their treadmills calibrated. This is done in an appropriate regulatory fashion. In addition to being able to walk more than 200 meters on a flat treadmill, their maximum walking distance has to be less than 600 meters on a constant load treadmill. So when you put the treadmill up to 12 degrees and at a constant speed of 2.3 miles per hour, they should not be able to walk more than 600 meters. So by providing, now this is not how you and I really diagnose PAD. Either the endocrinologists don't do it this way, neither the cardiologists or the vascular surgeons do this on a regular basis. And the reason why we use sort of stringent definitions like this is to just make sure that, one, we were in line with what the regulatory path was for this, and two, that we were not enrolling people who just had leg pain, who actually could have had neuropathy or other types of issues that were not related to peripheral arterial disease per se. Now, in addition to those two parameters, people had to have either an ankle brachial index of less than 0.9 or a toe brachial index of less than 0.7 to qualify. These patients were randomized to receive semaglutide 1 milligram once weekly versus placebo, and the treatment duration was 52 weeks. Now, you'll notice here that we enrolled people with diabetes, but we did not have a criteria for BMI or weight per se. This is not a trial of overweight or obesity. This is a trial of people with diabetes, and as you're going to see, a large number of them actually did not have overweight or obesity to begin with. We did assessments at various time points listed here, and as shown in the next slide, the primary outcome was a functional outcome, and that was the change in maximum walking distance from baseline to 52 weeks, maximum walking distance on a constant load treadmill. The confirmatory secondary outcomes included whether or not there was a persistence of benefit seen at week 57, i.e., 5 weeks after treatment was stopped. We looked at the change in the Vascular Quality of Life 6 questionnaire from baseline to week 52, which again is a validated questionnaire for PAD. We also looked at changes in pain-free walking distance from baseline to week 52. We had other supportive endpoints, which included the change in ankle brachial indices to see if there was an effect on hemodynamics. And we had an exploratory measure to look at progression defined as rescue treatment, major adverse limb events, or mortality. And most importantly, the primary endpoint was actually informed not only just in terms of change in maximum walking distance, but also we had an anchor measure that was patient reported. And as again, many of you know, when you are doing trials that are looking at patient reported outcomes, the FDA and the EMA really request or demand that anchor-based measures are used, i.e., the threshold that is clinically meaningful to patients needs to be defined. And then you need to evaluate your results through the lens of the patient-based anchor assessment to say, in the minds of patients, this is what the threshold was meaningful to them, and how did the results stack up. So it can't just be statistically significant, it actually has to be meaningful for patients using that anchor measure. And we did that in STEP-HFpEF and STEP-HFpEF-DM, as well as in this trial. So the baseline characteristics are shown in this slide, and no surprise, really, The mean age was around 68. Approximately 75% of individuals were male, 65% were white, and the other 35% came from other ethnic groups as listed here. The duration of diabetes was around 12 years, no surprises as well. Again, longer duration of diabetes is associated with peripheral arterial disease and other types of, vascular sequelae. And I would like to highlight the fact that the mean BMI was only 28.6, and that's shown right here. And furthermore, about 35 to 37% of individuals had a BMI that was less than 27. So this is not a trial of obesity or overweight per se. This is a trial of people with diabetes and PAD that were not enriched or enrolled with any set sort of BMI in mind. The GFR was mildly reduced at 53 mils per minute. LDL cholesterol was well controlled. Most people were on moderate to high intensity statins. And A1C was also reasonably well controlled at baseline, 7.0%. Blood pressure was well controlled as well. And no surprises, the vast majority of individuals, a high number of individuals, either had prevalent history of smoking or previous smoking history in keeping with what we know about PAD. Now, PAD is a highly comorbid condition, and has there's a clustering of other cardiovascular risk factors seen in people living with PAD: hypertension, coronary heart disease, prior coronary revasc, prior history of myocardial infarction, CKD were quite commonly seen in this population. So let me tell you about the types of people at baseline. How limited were they to begin with? And this is shown in this slide. You can see on panel A is the hemodynamics. And first and foremost, at baseline, we recruited the right people. They had to meet the Fontan 2A criteria, which I just explained to you a few minutes ago, but they also had to have an ABI of less than 0.9. And you can see actually that the ABIs were on 0.75 or 0.79 at baseline. So they definitely had PAD. And in terms of function, what is striking is, although this is the so-called quote unquote earliest stage of symptomatic peripheral arterial disease, people could only walk a median of 184 meters to begin with. So median maximum walking distance on a constant load treadmill was 184 meters. And that is, the normal distance should be greater than 600 meters. And in fact, many would argue should be closer to, 900 meters. So these were patients who had a low ABI and could walk on a median of 184 meters on a constant load treadmill. Now, what about pain-free walking distance? So sure, they could walk 184 meters in terms of function, but what about getting pain? And you can see here in terms of symptoms, the pain-free walking distance was already 109 or 119 meters respectively. So if you think of it, these are individuals who are quite limited in terms of their, function, symptoms, hemodynamics. And when we ask them in terms of quality of life, how would you rate your current limitation in walking ability? 2/3 of them said, well, I rate it moderate to severely impaired. So, we were happy to start with the right population to answer this question. So the primary outcome was the efficacy of semaglutide versus placebo in an intention to treat analyses on maximum walking distance and a constant load treadmill. And, we were pleasantly surprised here. And you can see that as early, the curves diverge in favor of semaglutide. For the primary outcome, which is looking at the maximum walking distance, i.e. the ratio to baseline at week 52. That was improved significantly. And in fact, the curves look like they continue to diverge. The curves seem like they're diverging early, even before 26 weeks. And then using the anchor-based measure, we asked the question, as shown in the pink box, are these clinically meaningful? And the anchor-based assessment for change in maximum walking distance was consistent with a odds ratio of 1.79 with a highly persuasive p-value for a clinically meaningful improvement in maximum walking distance. Now, on the right-hand side, you can see what does that translate into, in terms of absolute walking distance. And this is about a 40-meter increase in maximum walking distance on a constant load treadmill. As you know, the constant load treadmill, when translated into a flat surface, is about twice the amount. So, cilostazol is known to improve walking distance by just short of 40 meters on a flat surface. The improvement in 40 meters on a constant load treadmill is more consistent with about an 80-meter improvement in walking distance, maximum walking distance on a flat surface. So that is probably why the anchor-based measure shows an odds ratio of 1.79 with such a high, with such a persuasive p-value. So for those of you who are trying to, sort this out as to whether this is clinically or statistically meaningful, this is incredibly impactful for patients with PAD in a space for which there are zero treatments to improve claudication in these patients. So this was a real clear victory for the primary outcome. Now, pain-free walking distance also improved by week 52 with semaglutide. And when we asked the question, is there a disease-modifying effect, i.e., does the benefit persist even after therapy has been stopped for 5 weeks? We saw that that was also the case. We then asked whether these validated measures, the vascular quality of life questionnaire, was improved. Now, many of you as cardiologists and cardiology trainees are used to sort of KCCQ, clinical summary score for heart failure, right? Because you hear a lot about that, and we talk a lot about that. But similar to a validated questionnaire heart failure, there's a validated questionnaire in people with PAD, and that's the Vascular Quality of Life 6. And we also found a significant improvement in this quality of life questionnaire in people with PAD. Now, at the American Diabetes Association, we published another analysis in diabetes care simultaneously with the presentation that suggested that the benefits of semaglutide observed in terms of maximum walking distance were seen regardless of the diabetes duration, the baseline weight, the baseline A1C, the use or non-use of SGLT2 inhibitors or background insulin. So, there's no subgroup, at least demographically, that we can find that is either, a better or a poorer responder to semaglutide in this regard. And when we looked at the relationship between weight change and the improvement in maximum walking distance, this was very poorly correlated. So this is not a benefit that seems to be mediated through weight reduction per se. Neither does it seem to be mediated through an improvement in hemoglobin A1C, because there was no relationship between improvement in A1C and the improvement in walking distance with semaglutide. Finally, we not only found that semaglutide was effective on the orange, i.e. the function, the green, or the quality of life, but what was incredibly exciting, I would say, is that we found an improvement in ankle brachial index. And this is a real sort of direct proof of a potential hemodynamic benefit of semaglutide in this patient population, because, ankle brachial indices can only improve if there's improved perfusion, right? You can't, there's no other mechanism. And either it's an anti-atherosclerotic effect or it's a proangiogenic effect or whatever it is actually leading to improved perfusion in an area that's otherwise ischemic. And the fact that there is an improvement in ankle-brachial indices and that none of this seems to be really explained by changes in weight or A1C really point towards a vascular sort of these are medications that should be really coined as vascular therapies or cardiovascular protective therapies, in addition to all of the other things that we know about these medications. Now, finally, what about the composite exploratory endpoint? And, there's some very sort of seasoned trialists on the line here. I see Sean and I see Larry, and I just want to remind everybody here that many of us, including Sean and Larry and others, have been around the block, if I may, looking at exploratory analyses of small numbers. So please interpret this with a grain of salt. But it is in the main Lancet paper. It's a composite of rescue therapy defined as drop-in, intensification of therapy for, medical therapy, revascularization, or death. 14 events in semaglutide, 30 events in placebo, hazard ratio 0.46. So it does look quite dramatic, but as you know, small numbers tend to exaggerate the true effect. So it's good to see that, a hard endpoint of progression seems to be favorably affected, but we will need larger trials to be able to really determine the numbers here. I will tell you that the two other large trials of semaglutide, FLOW and SOUL, about 3,500 patients and just short of 10,000 patients in people with diabetes and CKD or diabetes and risk factors, have shown a hazard ratio of 0.56 and 0.71 for major adverse limb events, including risk of amputation in these patients. So the STRIDE trial, coupled with the results from FLOW and SOUL, all seem to point towards the fact that GLP-1 RAs are therapies to improve quality of life, function, symptoms, and limb salvage. And it's a completely novel attribute that none of us could have really predicted when the game started several years ago. Now, one of our wonderful colleagues, Ron Goldenberg, who is an endocrinologist, and he actually loves to quickly whip up meta-analyses. He has done this. These are unpublished data, but I do think that they may appear in an editorial in Diabetes Care in the not too distant future. But if you do look at the meta-analyses of EXCEL, FLOW, LEADER, SOUL, STRIDE, and SUSTAIN 6, this is trial-level meta-analyses. The point estimate for major adverse limb events is 0.78. So in addition to benefits on MACE, in addition to benefits on heart failure, there seem to be benefits also on major adverse limb events with GLP-1 receptor agonists. The safety profile was similar to the safety profile that we have come to know with semaglutide across people living with diabetes. Now, before I close, I also want to remind you that people living with PAD are at very high risk of CAD, right? And they're very high risk of MACE events. And, a few of us, again, Larry, myself, Mohammed Al-Amran, a few years ago had looked at SUSTAIN 6 and LEADER and asked the question, are the MACE benefits consistent in people with PAD who receive semaglutide or not? Because, there are other reasons why semaglutide needs to be prioritized in people with PAD, and that is for reducing atherosclerotic events. And you can see here in this analysis, as shown on the right, that in fact, the absolute risk reduction and the number needed to treat with semaglutide in people with PAD is quite competitive, if I may. NNT of 22, absolute risk reduction of 4.6, much greater than people without PAD and diabetes. So we know that in people with PAD who have diabetes, semaglutide can reduce major adverse cardiovascular events with greater absolute risk reduction, can improve limb outcomes, can improve functional outcomes, and can reduce progression of disease. So I think for people living with PAD, this is a clear winner. And I think it goes back to the story of the pump, pipes, filter, sugar, weight, and expanding prowess, if I may, of this class of medications. These are therapies that affect the heart, pump, the pipes, atherosclerosis, the filter, the kidney, sugar, weight, who knows what else. There's all sorts of the benefits in terms of sleep apnea, in terms of neurocognitive efficacy, in terms of addictions and alcohol use disorders, MASH, MASHLD, NAFLD. I don't know what the right terminologies are, but it's really a profound strategy. And to that, we really add now benefits on PAD. So finally, 2 slides. What do we think are the potential mechanisms of how these drugs work? Regrettably, that has been an area of limited high quality data. There's been some experimental data from animal models and some translational data that suggests potential direct effects of GLP-1 RAs on the endothelium, smooth muscle, cells, inflammation, lipid accumulation. Of course, these all occur in concert with the so-called indirect effects on hemodynamics, weight, and A1C, and they may set this may actually unleash an anti-atherosclerotic effect. Our group has been quite interested in this concept of vascular regenerative exhaustion. As you know, we run a translational lab focused primarily on vascular regenerative stem cell mobilization in humans with cardiometabolic disease. And we have shown, at least in retrospective analyses, that GLP-1 receptor agonists seem to improve the flux of vascular reparative stem cells in people with diabetes or cardiometabolic disease. And in fact, Brady Park, who is one of our PhD students, will be presenting one of the late-breaking translational abstracts at the European Heart Journal at the European Society of Cardiology, and that's his PhD thesis, which is a randomized translational study looking at mechanisms of benefit from a vascular standpoint with semaglutide in people with diabetes. And finally, there are other potential mechanisms of how these drugs could be beneficial, including reducing inflammation and immune activation, decreasing macrophage polarization, increased recruitment of vascular progenitors, angiogenic responses, and these in turn may have an impact to improve oxygen delivery and utilization, improve mitochondrial bioenergetics, improve microvascular recruitment, which then in turn could improve outcomes in people with PAD. So to summarize, in people with PAD and type 2 diabetes, semaglutide versus placebo demonstrated significant improvement in function. It met the anchor-based criteria for clinically meaningful change. It significantly improved symptoms and quality of life. It reduced disease progression. It surprisingly had a hemodynamic benefit within 52 weeks of improving ankle brachial indices, and it actually, its safety was consistent with previous clinical trials. So semaglutide therefore becomes the first therapy to reduce MACE events, improve cardiometabolic and kidney outcome, and improve walking capacity related quality of life and disease progression in people with PAD and type 2 diabetes in 25 years. And remember, in Canada, we don't have any anti-hyperglycemic therapy or any other therapy for that matter that is indicated to improve quality of life from PAD in this population. So I think this is it's a stride in the right direction, as we've said in one of the editorials in Cell Metabolism, that this does mark a change in the management of PAD in individuals with diabetes. And, again, should leave little doubt that individuals with both PAD and type 2 diabetes should be prioritized for treatment with semaglutide to achieve the triad of benefits expected from ideal therapy: prolonged survival, reduced cardiovascular and limb events, and improved symptoms. And that's essentially what we all desire for our patients. Whether these benefits will be seen in people without diabetes, whether hard endpoints in terms of prospectively, male events, all of those additional studies will have to be done, and they are being planned. But I think this is a first stride in the right direction for a disease that is often ignored, is undertreated, often is, doesn't get the attention similar to someone with an acute coronary syndrome, and often ends up with limb loss. And, we say this all the time. And for me, going to the ADA meeting this year and hearing from the endocrinologists and diabetologists who see this to say, this is a big deal for us. We see this all the time, and we don't actually have any treatments in diabetes for PAD, was quite reassuring that the question was important and the impact will be hopefully seen in this population. So thank you, Andrew, and I'll stop there.